Okay, I'd like to thank everyone for joining us this afternoon. This is part of our Neela Nights program, and like I like to say, it is nighttime somewhere. Today, we're honored to have my friend and colleague, Dr. Harold Bays, who's the medical director of the Louisville Metabolic and Atherosclerotic Research Center and is a clinical associate professor at the University of Louisville School of Medicine. He has been a principal investigator for over 500 clinical trials and has written or served as a contributing author to over 300 scientific manuscripts and book chapters, as well as authored and presented hundreds of scientific abstracts. Dr. Bays is board certified in internal medicine and endocrinology, metabolism. He's a diplomate of the American Board of Obesity Medicine and a diplomate of the American Board of Clinical Lipidology. Dr. Bays is Chief Science Officer of the Obesity Medicine Association and editor-in-chief of Obesity Pillars. So it's a great honor for Harold to join us this afternoon and give us a discussion regarding the role of GLP-1 receptor agonists in obesity therapy. So with that, Harold, thank you again and take it away.
All right, well, thank you very much. So as mentioned, I am a medical director of a research facility. I'm a clinical trialist, basically, and an endocrinologist, but also diplomate of clinical lipidology, as well as obesity medicine. And one of the areas of research that has really taken off in recent years has been the development of these GLP-1 receptor agonists. And so that's going to be my overall goal, is to give you the perspective of the GLP-1 receptor agonist from a clinical trialist. What I'm going to do at the beginning, it's going to sound like I'm not really talking about GLP-1 receptor agonists, but trust me, I'm going to get there, okay? But I have a plan. What I'm not going to be doing is giving you slide after slide after slide after slide of graphs and charts and data and all this other kind of stuff, because my sense is you're going to hear that from a lot of other people, and you could just go to any website and find that information. So this is more of a conceptual presentation than it is a data-driven presentation. So again, I'm going to be talking about GLP-1 receptor agonist. So conceptually, let's start from the beginning. So a lot of you folks work with patients with dyslipidemia, and dyslipidemia is a disease. Nobody disputes that. Hypercholesterol is a disease. Nobody disputes that. But it's quite remarkable how many people don't really consider obesity as a disease. So here's just a table that I would encourage you to look at if you're also kind of skeptical. Because in order to have obesity, you got to be diagnosed. It's got to have adverse consequences with increased morbidity and mortality. It's got to have causes, got to be treatment, and it's got to have people who are going to manage it. And if you look at each one of these bullet points, obesity hits every one of them. So in every respect, if you're going to define a disease, obesity hits that. The other thing is, if you're going to be managing people with diabetes, it might be a good idea to diagnose them accurately. Look, we do body mass index for a lot of folks. That's fine, but for a lot of other folks, it's not fine. So say, for example, in Black individuals, there's a whole lot of differences between Black individuals and whites with regard to particular cardiovascular disease risk factors and such. And body fat's no different. There's often a decrease in visceral fat, an increase in muscle mass among Blacks versus whites. And if you don't know that, then you might not be accurately diagnosing your patients. So this, by the way, this comes from this article, this roundtable, body mass index in Black and female individuals, race relevant or racist, sex relevant or sexist, which leads me to the next slide. Same thing with female individuals. There's decrease in visceral fat. We do a lot of DEXA scans for folks that just send in their body composition. And I mean, I just got one today, signed on one, where this female individual, her percent body fat is really good, and she has zero visceral fat. And that's something we see way more often than you would think in female individuals. We rarely, I could probably count on one hand the number of male individuals we have that have negligible visceral fat. And I think that's physiologically important. And why is it physiologically important? It's because obesity does have direct and indirect adverse effects on the heart, cardiovascular system, whether it be to the dysfunction of the adipose tissue, what we call the adiposopathy, or whether it be the fat mass disease, where again, you get the direct effects with the fat mass disease, many of you are familiar with HFpEF and such, and then the indirect effects where you're increasing the incidence of the cardiovascular risk factors like the diabetes, hypertension, dyslipidemia. So what's the current role of nutrition? And what we're finding, the primary care folks have known since day one. And I think the specialists are now just figuring this out, okay? Is look, the nutrition recommendations that we make for people with the obesity is really close to what we recommend for people who have the diabetes, the hypertension, the dyslipidemia, cardiovascular disease, and cancer. They're really not all that much different. I'm talking about the global principles and such. And here they all are. I'm not going to read them all off, but it's remarkable the similarities in nutritional approaches when you're talking about, again, what some people might have previously considered siloed and independent diseases, which they are not. And here's one that just drives me crazy. I have learned that if you want to get invited to do presentations and such, just say very silly things. And one that you hear from some speakers is, calories don't matter. Calories are not relevant. And I'm just like, how are you helping people by saying stuff like that? Here's a very practical example. Here's 100 grams of an apple, broccoli, candy bar, and bacon. I mean, I think this slide goes without saying. If you have 10 servings of apples per day, it's probably going to affect your health one way as opposed to 10 servings of bacon per day. I mean, again, this is just logical, common sense things. And just for the sake of making people feel better or less frustrated, we shouldn't just tell people things that are just scientifically inaccurate. Same thing with physical activity. The Obesity Medicine Association, again, for which I'm Chief Science Officer, yes, we also have the recommendation of, over 150 minutes moderate intensity exercise per week and such, and 2 days a week of resistance training. But we also add a minimal metric, 5,000 steps per day. And this is what drives me crazy, is people say, yeah, but are you counting the steps that people just generally, when they're moving around the house or moving at work, or is it explicitly when they're engaged in physical activity, physical exercise? Shouldn't that be what counts and not the other stuff? Folks, as clinicians, we're not step police. All right. So we just got to stop. For many of our patients who have the obesity, who are inactive, it doesn't matter how they get to 5,000 steps per day. If they get to 5,000 steps per day and they can walk into your office and they can point to their wearable technology and they can be proud because before they were walking maybe 1,500 steps a day and now they're up to 5,000. How is that not a good day? I think it's a good day. I don't care how they got it. So again, a lot of things we hear from folks, I'm not sure where they're headed or their intent. Same thing with resistance training principles. Primum non nocere. Just be sure that first do no harm. And there's this other group of recommendations. Mental stress, obviously. Look, people don't have weight. People don't have obesity because they have a lack of willpower. How do I know this? Here's how I'll know it. Look at your patients that come in to your office with obesity. How many of them are top of the line academicians or top of the top business people? They didn't have to have willpower. in order to become as successful as they are in most every aspect of their life, well, then what's going on with the obesity? You might want to say, well, we're carving that out as somehow, they don't have willpower. Look, that's just not what we intrinsically know to be true. The fact is there are a lot of contributors to obesity and mental stress, obviously, being one. The other thing is, folks, we've ginned up our food supply to just make it as difficult as we can for people with the obesity. I mean, what's supposed to happen is you have natural whole foods, and there's this balanced homeostatic effects on the brain, and that's helpful. And now your counter-regulatory hormones for the obesity, they all work like they should and everything, but that's not the world we live in. The world we live in is with ultra-processed foods that have billions of dollars of investment and advertisement to overcome this balanced homeostatic effects on the brain. And that's now you see where we're starting to get in to GLP-1, right? See where I'm going with this? And I know there are a lot of people out there, people like me, that immediately want to pivot and start railing on the food industry. Somebody's got to be a villain. Not the way I look at it. You open up a restaurant, you're wanting people to eat there. And if you find that putting a little bit extra salt on the food makes people happier and make them like their food better, you're going to put a little extra salt on the food. Maybe you put a little extra sugar when you're preparing it and such. These are just things that have happened over time when we figured out what people really, really want and what they're really, really going to buy. So I'm not one of those that want to gauge a lot in conspiracy and such, but I do think that people need to be educated about all this and understand that when you have ultra-processed foods, that's unhealthy. If you're consuming ultra-processed food, that's unhealthy. The other thing is, why is it that people, again, top-of-the-line academicians or top-of-the-line business people, how is it that they oftentimes have real challenges with regard to their weight when they're successful in every other aspect of their life? Well, let me throw this out at you. They've learned how to be efficient in their life. That's how they got to where they were, right? That's how they got to where they are. It's because they become very efficient. They're efficient in their work. They're efficient in where they park their cars. They're efficient in where they build their buildings. They're very efficient-minded people. But if you want to get to a healthful body weight, folks, you've got to learn how to be inefficient. And that's really hard for a lot of people, to become inefficient. You've got to not park the nearest to the building. You got to park maybe the furthest from the building in the parking lot. You don't want to eat foods that are ultra-processed that are efficiently absorbed. You want to eat natural foods that are inefficiently absorbed. You don't want a microbiota that causes efficient absorption of calories. You want a microbiota that's inefficient. And it's the same thing if you kind of go down the list here, and even come to things like the non-exercise activity of thermogenesis, the NEAT we always talk about, where again, if you look at each one of these examples, it's an example of inefficiency over efficiency. So let's talk about nutrition, what it does to people's body. All right, so you eat. Obviously the point of eating is to provide energy so your cells work, right? So you survive. Well, how does it affect the body with regard to hunger and digestion? Well, what should happen is if you eat, your hunger goes down, and then your digestion goes up. You have delayed gastric emptying, you have release of digestive enzymes and such, and then there's post-absorptive nutrient metabolism. That's how all these hormones work. It's a very logical system. So let's talk about it. Well, we just did that slide. So before you eat, it only makes sense. You've got to have some hormones kicking in there so that you'll be hungry, so that you will eat to prevent starvation. Well, that makes logical sense. And what are those hormones? Ghrelin and neuropeptide Y. And many of you have heard of ghrelin and such, okay? But after you eat, what should happen, there are all these hormones that are produced that said, okay, now that you've eaten, you shouldn't be hungry anymore, right? So it's going to decrease hunger, increase satiety in these things. And what are all these gastrointestinal hormones that do this? Well, there's one of them. glucagon-like peptide 1. Glucagon-like peptide 1. There are a lot of other ones here we've worked on with regard to potential anti-obesity agents. Things like glucagon agonists, pancreatic polypeptide, oxyntomodulin. A lot of studies we've done with them. A fibroblast growth factor. You've probably seen some of those being developed for fatty liver and such. Amylin, peptide YY. So looking across the board here, we are doing what we always do. Look at naturally occurring hormones and see if we can manufacture them in a way in which they are stable and can be administered pharmaceutically, and see if they work to treat the condition we're trying to treat. All right, what about other gastrointestinal hormones that slow gastric emptying? There we go. GLP-1, as well as the oxyntomodulin and peptide YY and cholecystokinin and amylin. What about stimulation of digestive enzymes, the digestive foods, gastrin, cholecystokinin, and secretin? And then after you start digesting foods, at some point you got to stop digesting the foods. So here's some counter-regulatory hormones that are produced. So it's all, it may not seem like it's regulated, but it is regulated, right? And then here are some hormones that assist with post-absorptive nutrient management: somatostatin, insulin, glucagon, fibroblast growth factor 19. The other thing you hear a lot from folks, and again, I'm not sure what the point of this is, but there are speakers out there, very bright people, great credentials, that will tell you people are predestined towards obesity due to an unalterable set point. Why would you tell people that? What is your intent? If your intent is to say, well, that way people with obesity aren't, people don't say that people who have obesity, that people don't say it's their fault. Okay, it's their fault. So let's talk about that for a minute. Folks, there's a big difference between blame and accountability. Blame and accountability. I 100% agree. If you have a person that's struggling with weight reduction, the idea that your session with to focus on blame, okay, they probably get enough from that from their family, their friends, their coworkers, and themselves, right? Sometimes people internalize, I'm a failure. I don't guess I have willpower, these types of things. So blame is out. We should take blame out of the equation. But to suggest that accountability should also be taken out of the equation just turns everything on its head. Because if we're not going to say, well, accountability is what we really need to be focused upon, then why on earth do we need dietitians? Right? That just seems to be a slap in the face of dietitians who say, what? Let's keep a dietary diary. Why are they doing that? Because they want people to see what they're eating and hold themselves accountable. Things like if you're going to have an exercise physiologist or a psychologist engaged, what are they going to be doing? Well, maybe they're engaged in behavior modification. Well, what is the primary tool for the effectiveness of behavior modification, if not for accountability? I mean, that's essentially what behavior modification does. It is intended to empower the individual patient to hold themselves accountable for doing certain things. But teamed up with that is the education to know what it is you're supposed to be accountable for, right? That's the key. So I think we need to be really careful about people who are predestined towards obesity due to an unalterable set point. It's not accurate. And how do we know it's not accurate? Well, the science tells us this. The other thing that tells us this, your own clinical practice. I can't imagine there's not a single person themselves or who has friends or who has families, members, or who has patients who haven't made substantial changes in their nutritional intake, substantial changes in their physical exercise or physical activity, that hasn't been able to make substantial inroads towards treating overweight and obesity. Now, obviously, it's really hard, and I get that, but it does happen. So let's just talk about them. So here are things that are largely unalterable. Look right. Things like age, height, genetic sex, genetics and neurological conditions. Okay, so these are unalterable. I give you that. But look at the ones on the left here. Nutrition and physical activity. Those aren't alterable. Those are, I understand people say they're set in their ways. If that's what you mean by set point, I get it. But that doesn't mean people can't change. I mean, I'm from Kentucky, and I've had patients come in and say, "Yeah, you don't know what it's like. I like Southern food, and I like my bacon, my biscuits, and gravy, and that kind of stuff. And you don't know what it's like." I'm like, "You're talking to the wrong person. I'm from Southern Kentucky, Warren County. Okay, I am perfectly aware of what kind of foods the people from the South eat, and we're going to have a conversation, right?" So again, I do think there's a role for accountability when we manage our patients with obesity. What about behavioral and environmental factors? Well, yet again, unless you believe behavior modification has no role in obesity management, I don't know how you can say that this is unalterable. I mean, what's the point then? Physical and mental health. Mental health's not important. We can't do anything to improve people's mental health. I think we can. I certainly think we can look at people's medications and see if they're on psychiatric medications that may be worsening their obesity. I think we can definitely do that. And then we can alter their satiety and hunger hormones. So you're starting to see how all this is coming together. So here are the ways we can alter body weight, alter set points, appropriate nutrition, physical activity, behavior, environmental factors, and then we talked about satiety and hunger hormones, which many times we can alter pharmacologically. Right now, there's the thinking out there that drugs should not be used to treat obesity because people are only going to regain the weight once we stop the anti-obesity medications. I mean, what kind of thinking is that? Right now, less than 5% of people who have the overweight and obesity are being treated with anti-obesity medications or bariatric procedures. Less than 5%. I will tell you, as of just like an hour ago, we just had a recruitment meeting, and apparently the use of GLP-1 receptor agonists is dramatically increasing. Now that the shortage is over, and now that it's being advertised frequently, we're starting to see where we used to see hardly anybody on GLP-1 receptor agonists. We're starting to see a lot of people on GLP-1 receptor agonists. So this chart right here, this figure may not be accurate for long. You say, "Yeah, well, we're lipidologists, so can you say something, speak to something that has to do with lipidology?" Well, sure. Look, if you have dysfunctional fat cells because your individual adipocytes become too large, or you've gotten adipose tissue accumulation, you have an increased release of free fatty acids, can't store it in your fat cells because they become dysfunctional, sick fat, or adiposity. Those free fatty acids can go to your liver. And then it can either remain in the liver and be fatty liver, or it can be secreted as VLDL particles, right? Very low density proteins. And then through the exchanges of the cholesterol ester transfer proteins, you get this exchange of cholesterol with triglycerides and your HDL particles and your LDL particles. And then when those particles have their triglycerides cleaved up, all different types of lipases, the lipoprotein lipase, hepatic lipases, this type of stuff. That's how we end up getting small dense LDL particles that are cleared through the kidney, or the increase in the VLDL remnants, or the small dense LDL particles. That's how we get this adipocopathic dyslipidemia that we see so frequently in our clinical practice. What about insulin resistance? I mean, that's also something that clinical lipidologists are very, very interested in. Well, it's the same sort of thing. You get adipocyte hypertrophy, increased adipose tissue accumulation, sick fat, and you get this hypoxia, if not adipocyte death, and you get lipotoxicity within organs, such as adipose tissue, adipocytes, or organs like the liver or the muscle, where you have an increase in the intracellular ceramide accumulation, which is toxic. You've heard of lipotoxicity, that's what we're talking about. Then maladaptive mechanotransduction. What on earth is that? Well, folks, if you're going to expand your adipose tissue is surrounded by matrices and such. Well, you got to break that down. And then you expand, and then you got to build it back up. And it's an ongoing process where you have a dissolution and remanufacturing of the matrices and such. And if that's maladaptive and you can't expand your adipose tissue, where's that excess energy going to go? Excess energy is going to go to the visceral area. It's going to go to your liver, going to go to your muscle, maybe your hands, maybe your kidneys. And then there's intraorganelle mitochondrial dysfunction, which yet again just messes up the whole machinery of your cells. All of it being dysfunctional. And then finally, you're going to get all these release of the adiposopathic factors, extracellular vesicles, or all these vesicles that can pinch off and deliver these things like bioactive endosomes, various different organs and such. So at the end of the day, you've got increase in stress, intraorganelle stress, you have generation of reactive oxygen species, and you have increase in phosphorylation, serine phosphorylation of insulin receptors, and that makes receptors not work. And then you have these chemokines where it attracts even more inflammatory cells, and those cells produce a lot of inflammatory factors, and you have reduced anti-inflammatory factors, like reduced as a result of decrease in adiponectin and such. And then you finally have an increased release of the pathogenic hormones, free fatty acids, bioactive exosomes. When you add all that together, you determine that effect upon things like muscle, things like liver, things like pancreas. That's when you get the insulin resistance. As far as the brain's concerned, look, we already talked about this. These hormones that are naturally produced, they affect the brain. And some of the hormones that affect the brain affects the satiety, hunger we've already talked about. And one of them being what? GLP-1. See where I'm going with this? All of this is integrated. All of it matters. Here's one specifically, and I'm not going to read the prescribing information to you, but we have the glucagon-like peptide receptor agonists. Things like semaglutide. I think that's a good representation of the class. Get around 15% weight reduction. As you know, semaglutide, when you're talking about diabetes and such, injection, pill form and such. And then the side effects, mainly going to be gastrointestinal in nature. And we encounter this all the time when we do our clinical trials with these GLP-1 receptor agonists. Sometimes we have to reduce the dose. Sometimes we have to stop the dose for a bit and then restart and dose escalate again. Try to get people to drink plenty of fluids, this sort of thing. So sometimes we have to use antiemetics. There are a lot of tricks to the trade and such about how to manage the gastrointestinal side effects. As far as contraindications, I think we all know, contraindicating patients with medullary thyroid cancer or known hypersensitivity. You have to be warnings and precautions with regard to the potential risk, pancreatitis, acute gallbladder disease, kidney injury. I want to focus on that just a second. Don't be surprised when you put people on GLP-1 receptor agonists and their creatinine goes up. I don't think that's emphasized enough. That happens. Okay, now over the long run, there's evidence that GLP-1 receptor agonists decrease the progression of renal disease and such. But in some patients, you're going to get an increase in creatinine. You're like, well, why is that? Is there a mechanism? Well, how about this? If people start to have nausea and vomiting or not consuming fluids as much as they should and such, then yeah, creatinine is going to go up. We had a tough case, a woman that in a trial, we asked her, she came in, we said, is everything going okay? She said, everything's great, doing super, okay. Ends up going to the emergency room 2 or 3 days later with profound dehydration and such. And we're like, why would you tell us everything was fine? And again, this was one of the GLP-1 receptor agonists we're doing. I'm not going to say which one and whatever, but I'm saying this as a general class point of view. We said, why wouldn't you tell us that you were having these problems? She said, because I was so scared you're going to take me off the drug. You need to be really careful with these drugs, folks, because people very much rely on these because they work and they work in a way like we've not seen. So here's what do GLP-1 receptor agonists do? Well, there we go. Decrease hunger, increase satiety. They increase insulin from beta cells. That's why they're called what? Incretins. Now, if you don't want to sound like you're very smart, you can say incretins, and that's fine. But if you want the proper way to pronounce it, apparently, what I've been told, and admittedly, I think this is more of a European bias or whatever, it's incretins. Okay, so just throwing that out there. Decreases glucagon from alpha cells, delayed gastric emptying, so that's also going to diminish people's interest in eating more food, but it also improves the functionality of adipose tissue. So here we go again, the importance of dysfunctional adipose tissue in the genesis of the complications of the obesity. And then we have this, then we have the GIP, right? Many of you are probably familiar with this. It's insulinotropic, peptide that's added. Okay, that's added in combination to the GLP-1 receptor agonist, and that, of course, is the tirzepatide. And what does the GIP add? Well, I can tell you it's not 100% clear. Maybe it decreases nausea. You don't hear that from people, but that's what I see in the literature. I don't know that it additionally decreases hunger. I don't know that. It does increase insulin from beta cells. Why? Because it's an incretin, right? Sometimes you get it called, twin cretin. That's what I call it, twin cretin, because it's it has two effects. The people that make this, I've been at meetings, and it's sad that we talk about such things, but they don't like that term at all. Okay, I think it's a pretty good term. It gets the point across, but they don't like that. So again, it isn't like two drugs that are put together. And I think that maybe that's the concern that they have. But anyway, the point is that not sure what it does to the stomach. I've seen reports that go a bunch of different ways, but it does seem to improve adipose tissue function. So all of those are good things. I don't know if you're familiar with mediator analysis, but these are analyses that are done where you try to attribute the effects of a particular agent on various metrics and such. And a lot of people have expressed concerns about this sort of methodology and such, but I think if it verifies what you kind of think you already know, I think mediator analysis is just fine. And what you can see here is, in this is the case, this is the liraglutide, but what you can see here is that how much is the effect of the liraglutide due to the intrinsic property of the drug, and how much of it is due to weight reduction? I mean, I think it's a perfectly legitimate question. Well, being that these agents, certainly at their lower doses, are also approved for treatment of the diabetes mellitus, well, sure, then it's intrinsically a property of the drug, these glucose effects and such. But when it comes to things like waist circumference, blood pressure, probably more to do with the weight reduction. So I see no problem with this sort of analysis because, again, I think it verifies what we think we already know. The other good news is a lot of these GLP-1 receptor agonists, not all of them, have cardiovascular disease outcome studies in patients with diabetes showing reduction in cardiovascular disease events. So, I think that's a really good thing. As far as GLP-1 receptor indications in cardiovascular outcomes trials, so again, some GLP-1 receptor agonists are indicated to treat type 2 diabetes mellitus and reduce major adverse cardiac events in patients with type 2 diabetes mellitus. And those are liraglutide, semaglutide, and dulaglutide. Tirzepatide is a glucose-dependent insulinotropic polypeptide, which I just mentioned, GIP receptor agonist, and a GLP-1 receptor agonists approved as an anti-diabetes medication. But there are ongoing cardiovascular outcome studies that are evaluating oral semaglutide in patients with type 2 diabetes mellitus. That's a sole trial. And semaglutide 2.4 milligrams subcutaneous per week in patients with overweight and obesity, not diabetes. Tirzepatide is being evaluated in patients with type 2 diabetes mellitus in the SURPASS cardiovascular outcome trial, and tirzepatide in patients with obesity in the SURMOUNT MMO. So, as excited as we were about these cardiovascular outcome results in patients with the diabetes mellitus, I think we're just as excited about the implications if these agents also show cardiovascular disease outcomes benefits in patients with the obesity. And you might say, well, but what kind of weight reduction are you going to require? Well, I think most people are of the mind that somewhere greater than or equal to 16% or 15%, probably going to get you cardiovascular outcomes benefits. But below that, there are going to be other benefits, even at just greater than or equal to 5%. Going to be improvement in some of the lipids and such. But if we're talking about hard endpoints or cardiovascular endpoints, we're at a different age because we've got agents that can do this now, that can give us 15 to 20% weight reduction, which brought us to an entire problem that I never thought I'd see in my lifetime. What do you do with patients who have excessive weight reduction with these drugs? We've had that problem. We've had that challenge in our clinical trials. And it is challenging, and I don't have time to go through it, but here's a paper with an algorithmic approach talking about excessive weight reduction with these highly effective anti-obesity medications. And so how is this all framed within the context of what you're accustomed to as in cardiovascular disease prevention, clinical lipidology? Well, folks, remember the early days we developed the early diabetes drugs and hypertension drugs and lipid drugs? At the beginning, there were a lot of skepticism, if not bias. First of all, saying you shouldn't be putting people on these drugs because if they would just do what's appropriate, that's what they would say. Do what's appropriate with regard to diet and exercise, they wouldn't be where they are, and we shouldn't be using drugs for them. Well, I mean, I don't know too many people think like that anymore, right? And so now we have highly effective anti-diabetes drugs, hypertension drugs, and lipid drugs and such. Let's talk about specifically. Folks, when I first started clinical research 30 years ago, we had fenformin, sulfonylureas, and pork and beef insulin. Oh my gosh. But then we went on to develop much better drugs. The DPP-4 inhibitors, and the metformin, and the human insulins, SGLT2 inhibitors, GLP-1 receptor agonists. What about hypertension? When I first started, we had people on guanethidine, hydralazine, methyl-dopamine. People felt terrible on these drugs. We developed the newer beta blockers, the calcium channel blockers, angiotensin converting enzyme inhibitors, and the ARBs and such. And it was a much better day. And what about cholesterol? When I first started, we used fire and sand. That's how we treated our patients. This is before statins. Okay, fire and sand. We put people on niacin, we put them on resins, fire and sand. But then we developed the statins, the ezetimibe, PCSK9 inhibitors, most recently bempedoic acid. So the point is, it's very analogous to the types of anti-obesity drugs that we've had in the past, where maybe not as effective as we like, maybe not as tolerated as we like, but the future looks very bright. And the thing that's going to take these drugs from not being used very often to being standards of care is the same thing that applied to the diabetes medications, hypertension medications, and lipid medications. That is, once we get cardiovascular disease outcome studies. And I would just leave you with this. Just like I think most of you are of the belief that diabetes mellitus, hypertension, and dyslipidemia, they're chronic diseases. I don't know anybody that thinks that once you have these, that they're cured. Maybe they can go into remission. They're not cured, right? We don't really cure people. Even with bariatric surgery, you may go into a remission. It's the same thing with obesity. So the question becomes, what happens if you have a person who has the diabetes mellitus and hypertension, whatever, can they ever stop their diabetes drug or their hypertension drug? The answer is, well, maybe some people can, but they have to be making pretty substantial changes in their nutrition, physical activity, other types of things. And I would say the same thing about obesity, is it possible some people may, once they get on an anti-obesity drug, may be able to come off their anti-obesity therapy? Maybe, but that should not be the expectation. It should be no more the expectation for anti-obesity drugs than it is for your diabetes drugs, your hypertension drugs, and your lipid drugs. So hopefully the point I've gotten across in this brief presentation here is that there's so many analogies between where we currently are with obesity and where we were with diabetes, hypertension, dyslipidemia just 20 to 30 years ago. And what I hope is that going forward, we're going to see a lot of other analogies where we're going to start seeing highly effective agents. We're going to see cardiovascular outcome results that are favorable with the use of these agents, and that then we can start maybe even using combination therapy to really get patients where they need to be. And maybe, just maybe, if we really start treating the underlying cause of the diabetes, hypertension, dyslipidemia, which occurs in so many of our patients, maybe we can start decreasing some of the other medications that they are on, maybe not stopping them, but decreasing the number or decreasing the dose of some of these medications. And most of all, hopefully patients will be doing better from a medical standpoint and from a survival standpoint. With that, I'll conclude the presentation.
Thank you, Harold. That was great, comprehensive overview of the story of obesity and the current role of GLP-1 and the future ahead of us. One question that had come up that you just touched on here at the end was if patients are on GLP-1 agonists, are they on it for life? And I think you answered that for us. Do you want to just comment further on that?
Yeah. And again, you're going to hear some people that are going to say, no, once they go on it, they're on it for life. Again, this world we live in of absolutism is just extraordinary to me. Okay, why don't we put this logically and within the context of how you would advise somebody if they're on an anti-diabetes drug or an anti-hypertensive drug or whatever, or a triglyceride-lowering drug? Okay, if you had one of these other drugs and they said, "Is there a time I can come off the medication?" Let's say they came in at 300 pounds, they had the obesity, whatever, but something changed. They were sent to a really amazing dietitian. They got working with a psychologist. They got themselves a really good, exercise program. Met up with somebody at the gym or met with a exercise physiologist, whatever, and they just totally changed, how they conduct their lives and such. If somebody like that started to lose weight with those sorts of to reduce weight with those sorts of interventions, would you tell them there's no way possible there's no way possible to ever stop your diabetes drug, your hypertension drug, or your triglyceride drug? I mean, you would just never say that. You wouldn't tell somebody that. I wouldn't tell somebody that. When we have people with weight reduction, whether it be through medications or whether it be just through nutrition, physical activity, whatever, we're so happy when we can stop some of these other drugs, right? We're thrilled. So it's not only possible, but it's like a really good day. I would say the same thing with the GLP-1 receptor agonist. How often is it going to happen? Ever, right? I mean, it's not going to happen that often. But to suggest that it could never happen, to suggest that there's no way a person can, achieve these sort of goals that they've set for themselves, I just think it's a disservice to patients. Now, don't get me wrong, it can't be, okay, great. You think you can really do it on your own. Why don't you just go ahead and stop your GLP-1 receptor agonist and better in 6 months? I would not do that, because the worst of all is that it took them 5 years to get to where they are with regard to their body weight. And many times it only takes like months and they're right back to where they were. And now they got to start all over. I would do that to anybody. So you are going to work with the patient towards getting off a GLP-1 receptor agonist that's being used for the purpose of weight reduction. I would encourage very close follow-up afterwards and make sure that the patient has realistic expectations, right? That there's total alignment, okay? That yes, you're supportive, they really think they can do it on their own, but on the other hand, we're just not going to drop the ball, and we're not going to feel guilty if it doesn't work out.
Okay, great. I think that's a great answer. And then along those lines, the safety issue comes up, and you can across the TMZ television, Ozempic face, and that's another question that comes up with regard to safety of these agents.
I mean, they're just people that just can't allow. We can't just have nice things, can we? I mean, there's just always people. Look, yes, particularly if you have, some of the higher levels of the obesity and such, if you have weight reduction, whether it be through bariatric surgery or proper nutrition, physical activity, or any types of things, there are going to be in some patients, some skin manifestation. I mean, that's going to happen. And people should be aware of that and whatever. But at the same time, folks, I mean, if it goes the way I think it's going to go, if we're saving lives, right? If we're preventing or diabetes mellitus or causing diabetes to go into remission, or if we're reducing blood pressure or causing it to go into remission, or if we're reducing triglycerides or causing it to go into remission, or if we're reducing the risk of cardiovascular disease, or if we're reducing the risk of cancer, right? Cancer, what's the second most common reversible cause of cancer? Well, second only to cigarette smoking, it's obesity, and soon obesity will be the #1 cause. So if you can prevent somebody from having cancer, and you can do all these other things, why would you not want to do this? So it's, I mean, yes, it would be great if any treatment that we prescribe would have zero potential for adverse experiences. Well, that would be fabulous, but that's not the world in which we live. So I think I would, rather than just always just seek out the negative, let's seek out the positive. And maybe go to a dermatologist if you can, or if that's an issue or whatever, or in the case of skin fold, where there's, as you know, people higher levels of obesity often have skin fold issues that require sometimes surgical correction, whatever. Let's look at it that way. But the idea that somehow we weren't going to, I'm not trying to be dismissive of that. I want to be clear on that. I'm not trying to be dismissive, but I do think that preventing a heart attack, if that's what the studies end up showing, heart attack, preventing the diabetes, preventing the hypertension, preventing the dyslipidemia, and preventing cancer, I think those are all really good things. I think those are things that we should consider doing for our patients if we have the option. So if you have the option of doing those types of things, I just don't see the downside. And if there are potential skin issues, let's resolve them in a different way. But I just don't think that increasing the risk of fatal heart, cardiovascular disease, which can be fatal, or heart failure, which can be disabling, or cancer, which can be disabling or fatal. I just don't see that as that the skin issues for most patients outweigh those potential benefits.
Okay, great. And I think another great point you made, Harold, is that it takes a village, involving the registered dietitians, the psychologists, the exercise physiologists to really, treat some of these people. So
well, and your nurses, particularly, like we rely so much on nurse practitioners here, the physician assistants, and then other clinicians. I mean, look, I just gave a talk at the American College of Cardiology. We are about this far away from, I think you're going to see the cardiologists step in a big way into this obesity space. I think it's just a matter of time. So my recommendation to all you clinical lipidologists out there that are engaged in preventive cardiology and such, I would encourage you, get on the boat now. Okay, get on the bus. You don't want to be not on the bus and just waving at people passing you by who are on the bus. All right, now's a good time to be your community expert in the use of these existing medications.
Great. And Harold, can you tell the group particularly that want to get, more interested in use of these medications about the Obesity Medicine Society or other ways they can get involved? They may not know.
Yeah. So as mentioned, I'm Chief Science Officer of the Obesity Medicine Association, a very clinical organization. The other thing is I'm editor of Obesity Pillars, and it is an Elsevier journal, just like Journal of Clinical Lipidology and such. These articles are free online, and we published probably close to 20 clinical practice statements and such. This information we've got roundtables, we have all kinds of stuff. So all kinds of resources, free. It's a free online journal. And if you have things that you would like to publish in the obesity space, let us know. Consider this journal. But overall, I think that there are medical societies. I think that there are journals that specialize in this space. But I would say this, because it wasn't that long ago, I would encourage the National Lipid Association to really think hard about, also being one of the key players in this obesity space. And I think there's plenty of room. Water's warm, right? I don't know how many metaphors I can use there, but the point is, I think it would be judicious and wise if the NLA would become, if it is not already, more of a driver rather than reactionary to this new space, because again, it's just like what happened 20, 30 years ago. And surely there's nobody out there who's a clinical lipidologist that isn't appreciative and isn't knowledgeable about the use of antihypertensives and diabetes drugs, right? I mean, it's all part of the same thing, and obesity should be no different. We need, gone are the days we just silo patients. Those days are gone. And I think from when I've talked to NLA folks, I think most people recognize that. And so I hope that the NLA really looks at this as an opportunity to really become drivers of what's coming, because I think it would be really helpful for patients.
I think that's great. That's a great point. And I think we hear you. So I want to just end with one clinical question that came up. Do you start GLP-1 inhibitors in patients who are already on insulin therapy? Do you adjust the insulin dose upon initiation? Yeah,
that's a great question. So the answer is yes. And what I would recommend is that when you initiate therapy with a GLP-1 receptor agonist in a patient who's on insulin, that you go ahead and preemptively reduce the dose of the insulin, right? Because you don't want to cause hypoglycemia. That's the worst. So I would do that. Now, here's another tip, something that I've seen in clinical practice that I would not have predicted. There's going to come a day when you all are comfortable, many of you probably already are, but when more people are comfortable with using the GLP-1 receptor agonist or the tirzepatide or whatever, you're going to see the day come more and more where you had a patient who was on insulin who now on a, what is today, Wednesday? On a Wednesday, they'll come in and it's in their best medical interest that they stop their insulin. That day's going to come, and you're going to walk in like I have and be all boastful, and all happy that you're going to be able to stop them from being on the insulin and such. And there are going to be patients who are going to be resistant to doing that. And you say, why? Why would you be resistant to stopping insulin? What? And there are people out there who have been on insulin for so long in their lives, right? That they feel like stopping it is dangerous. It's got to be an adverse consequence that they can't believe the good news. They can't believe that there's going to be news which is good. It's just really hard for them. So what we've done, this is a tip, is what we've done in cases like this is we will reduce them all down to some ridiculous number like 2 units or something, and then we'll have them take it like every other day. I know it sounds ridiculous, okay, and whatever, but it's not ridiculous for our patients, and that's what matters. It's like statin intolerance. There's some people out there that don't believe statin intolerance exists. I believe it does. People say the science doesn't support it. I disagree. I believe the science does support it exists. But it doesn't matter. If the patient believes it exists, we got to treat the patient. We're not treating the journals, right? We're not treating people's opinions. So what I would say is, if a patient is reluctant to come off the insulin, I think just some education and then accommodating their fears, their apprehensions, and say, okay, we're going to go down 5 units per day, maybe 2 units per day, and then we're going to go every other day. And if you have to, once a week or whatever, sooner or later they'll get the message, right? That it really isn't necessary. But those are good days. It is a great day. And I'm a clinical trialist. I mean, I developed drugs. But some of the best days I've ever had as a clinician when I'm able to take people off drugs.
Great point. All right, I think I would be remiss if I didn't let Greg, or as our president from the Southeast Lipid Association, ask a question. Greg, you have your hand up, so that'll be our last question for Harold.
Great.
Yeah, thanks, Guy and Harold. Great presentation, Harold. I'm a huge advocate of these meds. I have a ton of patients on them, and it is very gratifying to get people off insulin. When they come into my office on insulin, I'd say one of my goals is to get you off of this.
There you go.
But my question involves
hold on. Hold on. I didn't mention it, but this is National Lipid Association.
Right.
What most, so I'm getting ready to ask you a question.
Okay.
So what the literature suggests and what I've seen clinically is that in many patients, when you start to have weight reduction, whether it be nutrition, physical activity, or some of these medications, certainly bariatric surgery, the biggest initial or the most consistent improvement is going to be reduction in triglycerides. And then there's also, after a period of time, not in the short term. In short term, there can be decreases in HDL cholesterol, but in a longer term, there's an increase in the HDL cholesterol. But with regard to LDL cholesterol, unless you have clinically meaningful weight reduction, and I mean like greater than 10 to 15% weight reduction, don't be surprised if LDL cholesterol doesn't change very much. And what I would beg you not to do, because I've seen this, is to have a patient with familial hypercholesterolemia come in and say, if you would just lose weight, your LDL cholesterol would, so that can't ever happen. But my question to you, Greg, is this. You use a lot of these GLP-1 receptor agonists. I know what the literature says. I know what my clinical experience is. But what is your clinical experience? Not with regard to triglycerides and HDL cholesterol, because those get better. What is your experience with regard to the effect upon LDL cholesterol?
Well, I would say when the triglycerides go down, obviously sometimes you get a little LDL cholesterol increase because you're getting a bump in the particle size. We've seen modest ApoB reductions, I would say, when you get to that 10 to 15% or greater weight loss, particularly if the hyper ApoB is due to insulin resistance. So that's what I would say. Obviously, in the familial people, like FH people, we're not seeing much movement, in their ApoB.
No, you
but before we run out of time, Howard,
Okay.
Harold, My one quick question was this. There have been reports, and when people lose weight, they're losing a disproportionate or at least a significant amount of lean body mass. You hear this anecdotally, there's some stuff in the literature. And I'm hearing, and theoretically it makes sense that if you get people to take in enough protein and do their resistance training, you can minimize that. And that's not a reason not to use these drugs, but I'm just curious, since you're doing more DEXA scans than me, what have you seen? And do you have any comments about it? Because you don't want to lose lean body mass, obviously, right? I mean, that we want to preserve as much as we can. So I didn't know if you had any tips for anybody.
Absolutely. This is a really big deal. The one thing I can tell you is that if you go to the literature, it's going to be deceptive. It's just like any kind of interpretation of statistics. What you're going to see reported are mean effects or median results or whatever. But I can tell you the variance in the patients that we see, what happens to their fat reduction and their lean body mass effects is all over the place. It's so scattered. But it's exactly what you just said. So in general, what I would say is what we see from our DEXAs here is that it's almost a 1-for-1. For every pound of muscle, a pound of fat you lose about a pound of muscle. Now, that's not everybody, but on average, that's it. Now, some people lose more lean mass, included as muscle and such, and that is concerning. That's tough because you particularly women as they, female individuals as they get older, we concern ourselves with, sarcoosteopenia, which, the orthopedists see a lot. So we have to be careful with that. But I will tell you this. We had a patient that within 3 months had lost, I think close to 20 pounds. I'm like, oh no, he just probably crushed his muscle. His muscle actually went up by a couple of pounds. I'm like, what did you do? Well, this guy, and you can just say it exists or it doesn't exist, and it's a whole different lecture, muscle memory, whatever. But this guy used to be a big time athlete, and he just crushed it for those 3 months. I'm not recommending people do this. And the other thing he did was mountain biking. And apparently there's a big difference between biking and mountain biking, because with mountain biking, a lot of resistance and these types of stuff. So what I would say is, I think what you implied in your question is once people do start having clinically meaningful weight reduction, that whole business about resistance training 2 times a week and everything, you got to beef that up, folks. Right. You really need to do exactly what I think was implicit in your question, which is you really do need to focus on the resistance training. And if you do that, I would strongly encourage you to get body composition, not look at the scale. What is more frustrating? Have somebody that comes in, they go, oh man, I'm doing everything I'm supposed to with regard to, my eating, and I'm exercising like a fiend, but yet my weight hasn't changed that much.
Yep.
Right?
Yep. Yep.
And we've had that happen, and we look at their body composition, and their muscle mass has gone up and their fat has gone down, and we congratulate them. But if we just looked at their BMI, hadn't changed. Well, why would we discourage somebody like that? You just look at it and say, your body mass index, didn't change at all. So I don't guess you really did anything. That's not right. So I would encourage you all to really consider, maybe you don't have to have DEXAs like we do, but high quality bioelectrical impedance or something, and tell people the truth, diagnose them.
I'm glad we got a chance to bring that up. Sorry to run over, Guy. I just wanted to explore that a little bit. Thanks a lot, everybody.
Right, thanks.
It's great. We can have Harold here all day, but with that, Harold, thank you for joining us for Neela Nights, and it's great. It's comprehensive, and I think the NLA hears you. I think as clinicians, we hear you, and obesity is a major epidemic, and certainly has enough crossover with other disease states that we need to pay attention to it. So thank you. And again, look forward to seeing you soon.
All right. Very good. See y'all.
Thank you. Bye-bye.